It's my pleasure this morning to introduce a colleague and a friend, Dr. Guindi, Dr. Maha Guindi. So Dr. Guindi completed an anatomic pathology residency and liver and GI fellowship in Canada and became board certified in AP by the American Board of Pathology and the Royal College of Physicians and Surgeons in Canada. Her career as faculty in pathology started at the University of Ottawa in Canada in 1991. And then she moved to the University of Toronto, where she was between 2001 and 2011. At the University of Toronto, she was a recipient of the Wyman Berries Award for Excellence in Undergraduate Teaching at the university. She later joined the faculty in the Department of Pathology and Laboratory Medicine at the Cedar Sinai Medical Center in 2012. Right now, Dr. Guindi is a clinical professor of pathology at the Cedar Sinai's professorial structure. And soon after she got to LA, she received yet another award. So she received the Outstanding Mentorship Award by the Department of Pathology and Laboratory Medicine at the Cedar Sinai in 2014. Dr. Guindi's involvement in teaching includes educating pathology residents, pathology and clinical GI pathology fellows in the field of GI and liver pathology. She currently serves as the director of the GI and liver pathology fellowship, subspecialty, and the ACGME accredited training program. She's the director of the GI and liver pathology service as well, and she oversees a high volume service that includes inflammatory bowel diseases, major oncologic resections, and liver transplant related specimens, as well as complex pancreatobiliary resections. She is involved in several pathology national and international organizations and has been a speaker at several national and international meetings, including the OSCAR. She served as editorial board member for case reports in Pathology Journal, and she was the chair of the membership committee of the Hans-Popper Hepatopathology Society from 2012 to 2016. Dr. Guindi has contributed over 100 publications in peer-reviewed journals and book chapters. Her research interest, of course, is heavily focused on hepatocellular carcinoma and hepatocellular adenoma. And she has really done a lot of work on local therapies of hepatocellular carcinoma, prognostic and predictive immunomarkers. Specifically, Dr. Guindi has written, been an author of some of the big papers recently that have changed or improved the understanding of hepatocellular carcinoma. She was the lead author on a paper that looked at the effect of hypoxia in patients that were treated with transarterial chemoembolization, where she found that the hypoxia resulting from the TACE triggered the development or the growth of progenitor cell phenotype in hepatocellular carcinoma. And in that paper, she was able to show that those recurrent tumors after TACE, they tend to be of higher grade and they tend to have a progenitor phenotype. She was also a part of the group that first identified a series of driver genes in hepatocellular carcinoma in the early days of exome sequencing. She's been on the paper for so many documents that standardize the management of hepatocellular carcinoma. And she was one of the early people that defined, gave a definition to the diagnosis of early hepatocellular carcinoma. So there's a whole long list of track record by Dr. Guindi, especially in the area of hepatocellular carcinoma and hepatocellular adenoma. So I don't want to take too much more of our time. I'm really excited to listen to our talk, Hepatocellular Carcinoma, what's happening. So Maha, thank you again for being part of this morning.
Thank you so much for this kind introduction and lovely invitation. I appreciate it very much. As we were mentioning, this is a reunion of sorts for me with a very good friend, Deli, and also with Mahmoud. We hadn't seen each other for years. Last time I saw Deli was just pre-COVID. So I'm hoping we will get together again soon. I thought to talk about hepatocellular carcinoma because this is really a tumor that is coming into its own. in the last 10 years or so, and much has happened. The world of transplantation pathology has also allowed us to observe and understand aspects of the tumor that before transplantation were not really hot issues to deal with. So if I were giving this talk after fellowship, I will not mention how many years ago, I would be talking about differentiation, nuclear grade, tumor size, tumor number, and vascular invasion. So in other words, it would have been a very traditional morphology-based talk. However, we are in 2021. We are now in not just the space age, but beyond. And so now giving this talk, one would discuss novel histologic features, terminology regarding classification of hepatocellular carcinoma and liver cancers in general. What are the molecular studies and molecular classifications? What are their clinical and pathologic correlates? How can we do grading better to allow for post-transplant risk stratification using explant pathology? And of course, biomarkers. So now the talk becomes one about functional morphology, not just observational morphology. It becomes about features and surrogate markers that can predict behavior and treatment sensitivity, of course, in keeping with the era of precision medicine. So if we imagine how hepatocarcinogenesis might occur, if we start with a progenitor cell then has multiple pathways it could do. It can continue to multiply and remain as a progenitor cell, or it can grow up into big boys and girls over here. It may choose to differentiate down the line of a hepatocellular differentiation, and then become a mature hepatocyte, and then multiply autonomously to form a tumor. Alternatively, it can go down the path of differentiating along the lines of cholangiocyte, become a mature cholangiocyte, and then multiply to give a cholangiocarcinoma. But there are also other options. A mature hepatocyte may choose to give a tumor right away and may not necessarily reach maturity and then give a tumor. So understandably, the appearance of a tumor formed down this pathway would be different. Similarly, an immature cholangiocyte can become neoplastic or malignant at that point, and then multiply to form a tumor, which would presumably have different morphology than one arising from a mature cholangiocyte. There are more options. These cells could transition into each other if they wanted to. Or a mature hepatocyte could dedifferentiate into a less mature one. And similarly, a mature cholangiocyte can dedifferentiate into a less mature one and then form a tumor. And that's why primary liver carcinoma is so heterogeneous and can have many morphologic appearances. So when I mention primary liver carcinoma, I really mean hepatocellular and cholangiocarcinoma and everything in between. So traditionally, we have always thought of primary liver cancers that are malignant as being classic hepatocellular carcinoma and classic cholangiocarcinoma. But over the years, people have noticed that there are tumors that do not neatly fit into either categories. And there has never been very good nomenclature. These tumors were given names that were quite variable in the literature, making it very hard to either find them all or research them properly. And understandably, they have complex histologic and immunophenotypic features. And the big problem has been the lack of uniform terminology for all the in-between shades of tumor. So primary liver cancer does not necessarily have to be classic HCC or classic cholangiocarcinoma. After multiple attempts, a consensus terminology was developed by an international group of hepatopathologists who studied a large number of these tumors. And so their study used H&E-based diagnosis, and they looked at tumors that had mixed elements, hepatocellular carcinoma and cholangiocarcinoma, whether those two components are present at mixed or as separate areas, but within the same tumor. In that new terminology, those are the tumors that are regarded as mixed components or mixed hepatocellular cholangiocarcinoma. The entity of intermediate cell carcinoma got defined in this consensus, as well as the entity of cholangiolocarcinoma. So these have been, if you think of classic hepatocellular carcinoma and classic cholangiocarcinoma as two ends of the spectrum, the two clearer ends of the spectrum, these have been the in-betweens that have given us trouble over the years. So let's look at them in a bit more detail. So here is the classification, the consensus terminology. And I might add also that you will not see this in the latest WHO digestive disease book, simply because this paper had not been published yet while the fascicle was being written a couple of years ago. And so this consensus paper is probably the best reference to supplement what is currently present in the digestive disease fascicle. So on this end of the spectrum, there is hepatocellular carcinoma. On this end of the spectrum, there is cholangiocarcinoma, intrahepatic. And then we have the mixed tumors in between. Those are the tumors that clearly have hepatocellular areas and cholangiocarcinoma areas. What else might happen? Well, any of these tumors may have a stem cell feature or a stem cell or a progenitor cell component. What are stem cells? What do they look like? These are small cells, they're oval, they're quite tiny, and they mark with things like cytokeratin 19 and EpCAM. And they can also be found in classic intrahepatic cholangiocarcinoma as well. So the problem over the years has been, how do I call tumors that are classic HCC but have a little bit of stem cell? How do I call tumors that are classic intrahepatic cholangiocarcinoma but have either hepatocellular immunohistochemistry or have stem cell features? So those two epiphenomena in the classic tumors have caused some trouble classifying the tumors that either are hepatocellular but show cholangiocyte immunohistochemistry, are hepatocellular but show stem cell features as well, or are cholangiocarcinoma but have hepatocyte immunohistochemistry, or are cholangiocarcinoma but show some stem cell features. So let's take them one at a time. Let's start with the easy one, the classic hepatocellular carcinoma. This is easy. It looks like this. It looks malignant, and it looks like features of hepatocytes, big epithelial cells, lots of pink granular cytoplasm, central nucleus. No one has a problem diagnosing this as hepatocellular carcinoma. What about a hepatocellular carcinoma that has cholangiocyte immunohistochemistry? What do I mean by this? I mean a hepatocellular carcinoma that may stain also with CK7. Here is a hepatocellular carcinoma. Here is the CK7 performed on the same tumor. These tumors are still called hepatocellular carcinoma, having some cholangiocyte immunohistochemistry without any morphologic evidence of cholangiocarcinoma differentiation does not qualify the tumor to be a mixed tumor. What about the truly mixed tumor? Well, the truly mixed tumor would look like this. It has an obvious hepatocellular component, and it has an obvious glandular or cholangio component. This tumor is an H&E diagnosis. Immunohistochemistry is not a must here. Immunohistochemistry is done as a complementary or supportive evidence to supplement what we know by H&E. And so, for example, over here, if you stain this with cytokeratin 7, you will see the glandular component picking up cytokeratin 7. If you stain the same tumor with Hepar, you will see that this area is picking up Hepar and the glandular area is not. So this is the true mixed tumor. Well, what next? This is the end of the spectrum that's a pure cholangiocarcinoma, easy to recognize. It's a straightforward glandular tumor. As we all know, histologically, it's a diagnosis of exclusion. This diagnosis is further facilitated these days by sequencing because intrahepatic cholangiocarcinoma has a very distinct molecular genetic profile by sequencing. So this is how, this is how we deal with these. So basically, we come to the tumors that have a cholangiolocellular component. So what is a cholangiolocellular component? Not cholangio, but cholangiolo. So this is what a cholangiolocellular component looks like. It looks like a malignant ductular reaction. You have these cords of biliary-looking cells, and they may have these sinuous structures, and sometimes they might even have a semblance of tubular formation, and they sit in a desmoplastic stroma. When this entity was first recognized, it was thought to arise from progenitor cells, and people thought it actually arose from the canals of herring, because very often you will find it growing around rudimentary portal tracts. And the question really was very hard as to where to place this entity. And so the consensus now is that for a tumor to be called pure cholangiocarcinoma, it would have to be at least 80% composed of the cholangiolocellular component. This is actually very rare. Most of the time when we see a cholangiolocellular component, CLC, we actually see it either associated with an HCC or associated with a cholangiocarcinoma or associated with both. And so when we see a cholangiolocellular component associated with a hepatocellular carcinoma, it ends up in the mixed category. When we see it associated with a cholangiocarcinoma, it usually ends up in the category of intrahepatic cholangiocarcinoma. And this is an improvement on the prior attempt to classify these tumors. There is now some evidence by molecular studies that the molecular alterations in a cholangiolocellular component is closer to the molecular alterations in an intrahepatic cholangiocarcinoma. Finally, this is the entity that is probably not very common to see, but people are recognizing it more commonly. I have did the discussion with cholangiolocellular carcinoma. What about intermediate cell carcinoma? So intermediate cell carcinoma looks like this. This is a tumor that is truly in between. It's not mixed, it's in between, meaning that the morphologic features are intermediate between hepatocellular and cholangio. The cells are usually oval or cuboidal. They're usually present in sheets or nests. And it's very hard to arrive at an H&E diagnosis of cholangio or HCC on this tumor, and that's why it's named. If you did immunohistochemistry, this is the one tumor in this classification where immunohistochemistry is a must, because immunohistochemistry is needed to confirm the dual phenotype at the cellular level, meaning the same cell would express hepatocellular and cholangiocyte antigen. And so it's labeled intermediate, and it would, this picture which I showed you would comprise the entire tumor. The open questions right now is whether this entity remains as an entity by itself, or whether as we get better with immunostains, with diagnostic tools, with molecular studies, that we're able to better classify it and even perhaps give it a different name. Just a practical point, the morphologic differentials for this include a neuroendocrine tumor as well. So in its workup, we should always exclude the neuroendocrine tumor metastatic to the liver. So this is, I had very few cases of this. This is one of them. Here is the tumor. And you can see some of the cells are picking up Glypican. Some of the cells are picking Hepar. In the same areas, the cells are picking up CK19, which is a marker of progenitor cells. And sorry, I have something that is hiding my label. And this is alpha-fetoprotein here. So it's expressing biliary markers, progenitor markers, hepatocellular markers against this very undifferentiated appearance. So I mentioned progenitor cells in my talk, and this is perhaps a good segue to the next part of the talk, which has to do with molecular classification. And the issue is, why do we care about progenitor cell features, or what is also referred to as stemness in a hepatocellular carcinoma? We care about it because genome-wide transcriptional analyses over time have shown that the tumors that have the stem cell features actually are not very nice tumors. They downregulate hepatocyte differentiation genes, and they start to commit to a biliary lineage. And when we did integrative genomic analysis on such tumors, it was clear that they are enriched in progenitor type signatures. What do we know about progenitor aspects in tumors? Well, it's usually viewed as an adverse prognostic factor in hepatic malignancies. Other papers have shown that if you took HCC and stained it with keratin 19, if it had positivity, these multiple studies show that such HCC with stem cell features have a worse prognosis. They also have worse post-operative survival. And this was reported in a group of mixed tumors that also exhibited more than 5% positivity for stem cells or progenitor cells. Other studies that have done flow cytometry showed that mixed tumors that show a site population of stem cells are more chemoresistant compared to classic HCC or classic HCC. So this is a nice segue to the molecular classification of HCC and its histologic correlates. Yes, such a classification has emerged in the last 5 years and is getting better and better developed. So as we all know, HCC is a tumor with a very high degree of molecular and histologic heterogeneity. Thanks to studies using high throughput sequencing, gene expression profiling, and transcriptomic analyses, we were able to identify multiple transcriptomic subclasses of HCC. We were also able to recognize that there are numerous recurrent genetic alterations in HCC, and that several HCC subtypes, molecular subtypes, correlate with distinct HCC morphologic subtypes. And that for some of these subtypes, the HCC appearance or phenotype is very closely related to particular gene mutations. So let's think of how hepatic carcinogenesis might happen. So hepatic carcinogenesis, here is a cirrhotic liver, and this is all we're talking about today, is just cirrhotic liver. So cirrhotic livers then start to develop dysplasia, beginning with low-grade dysplasia to high-grade dysplasia to then hepatocellular carcinoma. On the morphologic end, once we enter dysplasia, the morphologic features are characterized by high density of cells, an increased nuclear to cytoplasmic ratio, and increasing features of nuclear atypia. All of these features increase until distinct high-grade nodules are formed, and then these high-grade nodules give rise to hepatocellular carcinoma. This is the dysplasia carcinoma sequence we understand in HCC arising in cirrhosis. So there are major pathways involved in the generation of HCC. A very early change is third promoter, and as you can see that third promoter abnormalities increase as you move from low grade to high grade to full-blown HCC. And these are some of the other involved molecular alterations in HCC. The Wnt beta-catenin pathway is heavily involved. The cell cycle regulation genes are very heavily involved as well. And these represent, together with p53, the most frequent alterations in hepatocellular carcinoma. This is the molecular classification of HCC as we understand it now and as it continues to get tweaked. And this is a busy schematic, but the important thing is that there are really two big groups of HCC. There are the group that is known now as the proliferative group. And the proliferative group is characterized by genetic alterations in the genes that have to do with control of the cell cycle. And these tend to be the worst tumors. And then the other group is the non-proliferative group. They're characterized by chromosomal instability and by the Wnt pathway activation. And this is the chromosomal unstable group. You will also notice some of the features, some of the infections, the viral infections that are associated with this group, and some of the mutations involved in this group. So we talk of G1, G2, G3, 4, 5, and 6. And as we move through the next part of the presentation, I will be showing you examples of the now studied subtypes that fall into these categories. This is, to give credit where it's due, I modified this schematic from a very nice review by Jessica Zuckman-Rossi that came out in 2019. After much work has been done, this combines the histologic features, the molecular classification, the genetic defect, and the oncogenic pathways. So if we take the proliferative tumors, remember from the previous diagram, these are the tumors that fall into the group where there is cell cycle dysregulation. These are the chromosomally unstable tumors. These are the tumors that are generally poorly differentiated, and they have some of the nastier subtypes. They have the progenitor subtypes, meaning hepatocellular carcinoma with progenitor features, which we just spoke about, and I mentioned the studies that show that they tend to have worse prognosis. So it's no surprise that they actually fall under the proliferative chromosomally unstable group. They also include a newly described subtype of HCC known as Macrotrabecular massive hepatocellular carcinoma. This is a subtype of HCC that's aggressive, that loves vascular invasion, and I will be showing you an example of this. It also involves a subtype that's not very common, but also is one of the bad actors, which is Scaris HCC. Under this group of so-called proliferative tumors falls the G1, G2, and G3 subtypes in Zuckman-Rossi's molecular classifications. There are other molecular classifications that have different names. There is one by Hoshida that has S1, S2, and S3. And as you can see, this is, for example, Zuckman-Rossi's G2 and G3 would comprise Hoshida's S1 subgroup. I think the name doesn't matter in as much as we understand where they fall in being proliferative, non-proliferative, chromosomally unstable versus chromosomally stable. So again, genetically, the proliferative group are chromosomally unstable or unstable. They are characterized very much by p53 mutations. And here is another bad one. Fibroblast growth factor is amplified. This is one that's quite operative up here in the massive macrotrabecular HCC. And oncogenetically, this group is characterized by the upregulation of cell cycle genes. Here is the nice group. And the nice group are the non-proliferative tumors. So histologically, they're well differentiated. They include some of the more familiar subtypes like steatohepatitic hepatocellular carcinoma and the CTNNB1 mutated hepatocellular carcinoma, which I will also show you pictures of. So in Zuckman-Rossi's classification, the paper, the first author of this paper being Boyo, G4, G5, and G6 fall in this group, and it's Hoshida's S3. These, I apologize for this typo, these are chromosomally stable. They're characterized by these mutations. And basically, they maintain hepatocellular markers. And that's why they're histologically much better differentiated. And for example, they continue to make albumin and so on. So what are the subtypes of HCC then that come out of such a molecular classification? Let's look at the CTNNB1 HCC. So this gene encodes beta-catenin, which is a transducer of the Wnt signaling pathways. And when it's mutated, it stabilizes the beta-catenin protein, allowing it to accumulate in the nucleus and leads to cell proliferation. When we look at these tumors in resections or explants, these are large tumors, but their size doesn't seem to impact their clinical outcome. And as I mentioned, they retain expression of features that we associate with hepatocellular differentiation and function, like albumin. They are also characterized by dysregulation of the bile salt transporters in the tumor. And so these tumors are cholestatic. What do they look like? They look like this. So they're narrow trabecular. They're easily recognizable as hepatocellular. Therefore well differentiated. Therefore, they maintain their hepatocellular markers of differentiation. And you can see they're characterized by these pseudoacini here. They're gland-like structures, but they're actually lined. They are spaces surrounded by hepatocytes. You can think of them as a giant canaliculus. And as I mentioned, these tumors make bile, and you can see a big bile plug in one of the pseudo-SNI over here. So this is this subtype. What about the steatohepatitic subtype? You notice I'm starting with the nicer subtypes. Steatohepatitic means it shows morphologic features that we associate with steatohepatitis, except it's occurring in a tumor. They somehow more frequently develop in NASH patients. We're not sure if the neoplastic cells are actually sensitive to any metabolic dysregulation in the patient. They fall in the G4 subclass and are non-proliferative, and they're characterized by upregulation of interleukin-6 and therefore upregulation of the JAK-STAT pathway. And so they would stain with C-reactive, it affects the C-reactive protein gene. And if you would stain it with CRP, C-reactive protein, it is actually overexpressed in these tumor cells. These tend to be small tumors. They don't tend to generate satellite nodules or do vascular invasion. They have good clinical outcome. This is what it looks like. It looks like steatohepatitis with ballooned hepatocytes with medullary body formation, except this is in the hepatocellular carcinoma. What about the clear cell subtype? The clear cell subtype, as its name implies, is made of clear cells. And one word of caution though, its biggest differential diagnosis is actually this entity. So if we get a liver biopsy with this, we have to entertain that this could be a clear cell HCC, but we have to remember all of the other tumors that make clear cells, of course, especially clear cell renal cell carcinoma. So if it reminds you of it, think of clear type of HCC. What about the chromophobe HCC? This has a very distinctive cytoplasm. It may superficially resemble the clear cell subtype because the cytoplasm has some clearing. The nuclei are quite uniform, but here is where the diagnostic feature is. Every so often, against this background of uniform nuclei, you get sudden anaplasia. You get the sudden cluster of single tumor cells or clusters of tumor cells that have this very striking anaplasia with lobated nuclei like this. This is what is helpful in the diagnosis of this subtype. The Scaurus subtype is formed of clusters of neoplastic cells. It has a very dense fibrous stroma. It's a rare tumor, 5% of resected HCC. The studies showed that it does express progenitor and cancer stem cell genes. What are these? Cytokeratin 7, cytokeratin 19, CD133. It does have activation of the TGF-beta pathway, and it also has activation of pathways of mesenchymal epithelial transition. And its clinical outcome is controversial. Some people believe it has a worse outcome. Other people think it's so rare that we really don't have big enough series to prove that it has a worse outcome. But just the expression of progenitor features or stemness makes one think that it probably does have a worse outcome. Here is an example of such a lesion. Here are the groups of cells in a dense desmoplastic stroma. Here is the new subtype, the macrotrabecular subtype. This is a bad actor. It forms about 10 to 20% of all cases of HCC. What is the big characteristic? It has very wide trabeculae, which are more than 6 cells thick. It actually frequently occurs in patients with hepatitis B. The case I'm about to show you is my case and was from a hepatitis B patient. They clinically have high serum alpha-fetoprotein. There is good inter-observer agreement about diagnosing this subtype, but it's very aggressive. Part of its aggression has to do with the upregulation of angiogenesis, and so a lot of vascular invasion. Satellite nodules are frequent. These are some of the angiogenesis activated genes: angiopoietin-2, vascular endothelial growth factor, VEGF, and FGF. And it falls in the chromosomally unstable group in the G3 transcriptome. Here is an example. Here is the low power view showing the big trabeculae with all the sinusoids in between. It is actually believed that this gives it amazing access for vascular invasion. Here is a reticulin stain that shows loss of reticulin, but more importantly, it really highlights the very wide trabeculae of the tumor. So this has TP53, it expresses cytokeratin 19, and it does vascular invasion. It has all the bad prognostic features. So progenitor HCC is not a separate subtype. It's really not a variant per se. It's any HCC that happens to express cytokeratin 19 in more than 5% of its cells. Cytokeratin 19 is a marker of both progenitor cells and of biliary lineage. So bile ducts will stain with cytokeratin 19, as well as progenitor cells. And we don't know if basically such a phenomenon arises from dedifferentiation of neoplastic hepatocytes or from malignant transformation of progenitor cells. We looked at the development of a progenitor cell profile after locoregional therapy. These are pictures from our paper. We took a number of HCC that had been treated with transarterial embolization chemotherapy. These are tumors which are rendered hypoxic by the embolization. And of course, by the time we get them, have undergone necrosis. And we looked at the expression of progenitor/biliary markers and hypoxia markers in the tumor. And so here is a picture that shows you that this really has hepatocellular carcinoma morphology. This is the gross appearance of one of our tumors. And you can see the tumor looks necrotic with some residual viable. This is proof that these are taste. These are the taste beads that are loaded with the drug and are injected in the arteries feeding the tumor. And we co-localized both cytokeratin 19 and CA9. CA9 is a marker of hypoxia. So CA9 here is staining with red chromogen and cytokeratin 19 is staining with brown chromogen. And you can see that they co-localize, and you can see that any residual viable tumor is actually expressing both. So the theory was that the hypoxia generated by the TACE may actually promote a more aggressive phenotype by favoring either biliary differentiation or progenitor cell differentiation. Our control group was a group of HCC that had never been treated, and we certainly found statistically significant differences between the two. What about lymphoepithelioma-like HCC? Like its counterpart in other organs, it's characterized by massive lymphocyte infiltration. It's a rare tumor. It has improved overall survival. It's felt that these lymphocytes constitute anti-tumor immunity. They mark with CD8, and these tumors show increased expression of PD-L1. They are microsatellite stable. They do not have increased tumor mutational burden. To date, there is no data to associate them with a particular transcriptomic subclass or genetic alteration. This is what the tumor looks like, and according to WHO, the lymphocytes should be outnumbering the tumor cells to make a diagnosis. So this is a summary of the subtypes of HCC that currently exist in the WHO. I have shown you pictures of all of them, except perhaps for neutrophil rich. I don't have an example of this. This is a summary to show their relative frequency, the key clinical correlates, some of which we have discussed, and the impact of the subtype on the prognosis. So the ones that fall in the non-proliferative group, the G4, 5, and 6, have a nice prognosis. And the ones like macrotrabecular that fall in the in the proliferative subgroup have a worse prognosis. I also highlighted in yellow those tumors that we really don't know of a transcriptomic or genetic correlation yet. Two patterns of growth that we notice in explants that I'm kind of exiting the part about the molecular classification. I feel I should mention these because these are features of HCC that we recognize in explants. They are not yet associated with any particular genetic alteration, but they portend a bad outcome. Serotomimetic means that the serotic nodules look like the pattern of cirrhosis, but the nodules are no longer made of benign hepatocytes. They're made of hepatocellular carcinoma. This is a rare pattern. There isn't really, we're not sure if when this pattern happens, it's because there is a distinct molecular feature or because it's just a growth pattern, perhaps helped by vascular dissemination. But usually prognosis is poor, and the cases I've seen have had a heavy tumor burden. This is another ongoing problem in hepatocellular carcinoma, one that has been brought to the forefront by transplantation and explant pathology. Well, if we have multiple nodules of HCC, how do they relate to each other? Are they all metastases from each other? Are they all intrahepatic mets? Are they multiple separate tumors that each has arisen independently? Do we have a way to distinguish these two scenarios? So if you look at the gross, people feel that if you have big tumors in the gross and portal vein invasion, that it makes sense to consider that one is a primary and the other is an intrahepatic met. That if you had multiple small tumors, they would be too small to maybe generate metastasis, so we would consider them multicentric HCC. And if you had one big tumor with multiple surrounding little nodules, that this is a tumor with satellites. This is theory. This is not foolproof. This is how people are thinking about this. Well, what about at the microscopic level? Well, one school of thought says, okay, if you have multiple tumors and two of them are very low grade and one is very high grade, it would make sense to think that this is perhaps multicentric with two nice tumors and one bad one. Or if you had multiple tumors, one of which is just arising from its precursor lesion, which is the surrounding high-grade dysplasia, and one is an advanced tumor, moderately to poorly differentiated, then odds are that these are separate events because it's unlikely for an early well-differentiated tumor to metastasize in the liver and form a poorly differentiated tumor. So that scenarios like these with G1 here meaning low grade histologically, these are scenarios that would lead us to think that these are multicentric independent tumors. So if you had three nodules that all looked the same and all looked moderately to poorly differentiated, then we can surmise these are all intrahepatic mets from each other. This is also not foolproof. A very nice paper from Johns Hopkins by Laura Wood that used targeted sequencing. And they actually had a large number of cases, over 100 cases. And even with sequencing, they were only able to resolve it in about 60% of their cases. And the ones that they resolved, the outcome that was revealed by the sequencing was actually did not always correlate with the impression on the microscopy. In other words, some tumors that looked like they are different tumors, when they sequenced them, they realized, oh, they're all the same tumor. So this is a difficult problem. Sequencing or targeted sequencing, showing which molecular pathways or alterations are present, could help clarify the relationship of some of these multiple nodules to each other, but there remained a good 40% in their paper where this was not possible. I want to touch a little bit on WHO grading. So by that I mean well-differentiated, moderately differentiated, and poorly differentiated by H&E. So I show you here the definitions of WHO grading as they sit currently in the WHO fascicle. You will notice they're very descriptive. They're not terribly quantitative. And if you look at the nuclear grading, it's the same problem, that it is descriptive. It's not exactly quantitative. And so if I wanted to show you a low-grade tumor, this would be a very well-differentiated G1 tumor. Then they get worse as all the malignant features increase, and then finally they end up with very poorly differentiated hepatocellular carcinoma. This presumably, of course, would have a worse outcome. But there are problems with histologic grading. If we use histologic grading as a method of risk stratification and prognostication, then we need to have a good system of doing so. We do not do this pre-transplant simply because the organizations that govern the guidelines for transplantation do not require a tissue diagnosis for tumors in cirrhotic livers. HCC is still a radiologic diagnosis, the one oncologic site where tissue diagnosis is not required. And so any pre-transplant risk stratification is based on imaging, based on tumor size and number of tumors. But liver transplantation is becoming more and more therapy for HCCs. And what we can do in HCCs and the explants is do post-transplant risk stratification. And so there have been multiple studies that show that histologic differentiation is a better prediction of tumor recurrence compared with imaging post-transplant. And so what are the problems with the WHO grading system? Its criteria are not really precise. It's predicated on a collection of architectural and cytologic features per grade. And it becomes very difficult for the human brain to incorporate these multiple observations and synthesize a consistent grade. There's a great deal of subjectivity and low level of agreement. And so this attempt was made by Sanjay Kakar and group to develop a recurrent risk assessment score. This is not something that is standard in use right now, but I think it's a great attempt to bring some structure and some consistency to doing so. So they assigned a specific weight to distinct features. They had moderate agreement improved over the WHO, and they ended up with 4 histologic features: tumor architecture, NC ratio, nuclear pleomorphism, cytoplasmic amphophilia. They used these to create a composite score. And so this is what their score looks like. So when they took their tumors and then did risk assessment using this score versus doing it the traditional way using the WHO, their method was better. So the cases that they classified as low risk and gave it a point score of 0, their recurrence rate in their series was 0%. Cases they classified as intermediate risk using this score, their recurrence rate was 12%, so a bit more, but not the highest. And cases that they classified as high risk by their score, their recurrence rate was the highest at 54%. And that performance was better than WHO. We cannot end, I have to end this talk with biomarkers in HCC. Why do we need them? For prognosis and response to therapy. We also mentioned that while HCC is most frequently associated with mutations in beta-catenin, third iridia, and TP53, sadly, we do not have efficient therapies for these particular mutations. These are the available agents that we have in the event that systemic chemotherapy is required. We really need better ways of knowing which tumor will respond to which agent, and that's why we need biomarkers in HCC. And my sense is that the role of HCC subtypes and their sensitivity to different therapies may become important. Once we actually have biomarkers, hopefully biopsy will return to HCC because then it would be used to generate this information. So what can we stain for at present? Well, we can stain for MET. The trial that was used for treating HCCs with mutations in MET using this drug was a negative trial. So we need other drugs that can work in high MET HCC. People have looked at Glypican, which is involved in cell proliferation, and tried to develop some monoclonal antibodies targeted against Glypican. And then, of course, people have looked at PD-L1 blocking agents and using PD-L1 immunohistochemistry to guide this. In hepatocellular carcinoma, both neoplastic cells and immune cells can stain for PD-L1. There are issues with the pattern and level of expression. Some of the problems encountered are a little bit similar to those encountered in lung, which is, do you look at the macrophages, the lymphocytes, versus the lymphocytes or the tumor cells? This was the trial for using Glypican as a biomarker, using a monoclonal antibody to stain against or to block Glypican. It ended up being a negative study. And we did a paper looking at this, and we used the same complex scoring system that was used in this paper. And the purpose of this table is to just show that the scoring system involves membranous components and cytoplasmic staining, and you combine different levels to come up with an overall score. But this is what we found. This is from our cases. Here's an HCC. Look how heterogeneous Glypican staining is. But also importantly, if not every cell is going to have membranous staining, again, heterogeneity of Glypican. First of all, it's heterogeneous. Secondly, the heterogeneity is encountered significantly less in biopsies. We had matching biopsies with our cases, and the percent biopsies that stained for Glypican was less than the corresponding resection. That again, if the staining is heterogeneous, that becomes a sampling effect. There is cytoplasmic staining with Glypican, but there is also membranous staining with Glypican. So if you generate a drug that's supposed to attach to Glypican on the cell membrane, what about those cells that don't have membranous staining of Glypican? Would the drug work on such cells? Is that the reason for a negative trial? That maybe that if you had too many cells without membranous staining of Glypican, your drug cannot attach in the first place. So we presented this at USCAP. The final thought I leave you with is, this is a study that we already submitted to a journal and are hopeful it will get in. We looked at different stages of HCC by size and by biology. So small early HCC, small but progressed. Progressed meaning it looks like moderately or poorly differentiated, but small in size. Large, well-differentiated HCC, large but moderately differentiated HCC. And we did tumor mutational burden on all of these cases. And basically we found no significant difference between the background cirrhosis and the small early HCC, and no significant difference between small and early HCC and small and progressed HCC. So it doesn't seem to change between background liver and early HCC, and it doesn't seem to change between small HCC and big HCC. And HCC is generally a tumor that falls within the low end of tumor mutational burden as a group. We were hoping to find some differences or to look for differences when we divided the tumors by size and by level of progression. But what I found interesting in our study is that this part, no significant difference between cirrhosis and small early HCC. Why? Because on biopsy, this can be a very difficult distinction. And the more diagnostic tools you have to distinguish between cirrhosis and early HCC when the tumor is super well differentiated, and on biopsy, you may not be sure that you're dealing with a tumor. Any tool, any immunostain such as Glypican can be helpful. But it became clear to us that tumor mutational burden is not going to help us in this setting. So I'm going to end here and happy to entertain any questions. And I sincerely hope that we can see you in LA next year and even sooner, if that's even possible. Thank you.
Wow, thank you very much, Maha. Just that was quite impressive run through of all the things that are happening and the things that have happened and the things that are not likely to happen with HCC. So we are open for questions now. So I believe there are probably one or two questions. So just unmute yourself if you have a question. So while we are waiting for the question, I have one for you, Maha. So when you look at these different histologic types, especially the ones recognized by the WHO, the macrotrabecular, massive, and all those things, we see them. And now we try to just put it as part of the discussion. But at the end of the day, when the oncologist has to make that call, they still have to rely on the stage, irrespective of the kind of histologic type that you are diagnosing. So my question, so I think the science is showing that size for size, the macrotrabecular is likely to present at a higher stage than the clear cell, for example. So what exactly will be the utility of separating macrotrabecular from the other type when at the end of the day, the decision is going to be made based on the stage of the disease at that time?
So I think that we need clinical trials where the subtype is known prospectively. And And then we can see if multivariate analysis would show that it's an independent factor from the actual stage. I think all of our trials so far have been, like Milan, for example, have been based on number and size, because the molecular classification and the correlate histologic subtype had not been really well developed. And the other part where this has not occurred is that because no biopsy is done ahead, sometimes they really don't know what they're treating. And so I think first we need to do subtypes that include, we need to do trials that include the histologic subtype, and then see if it shakes out as independent prognosticator from stage. And the other issue is knowing the subtype. If we know it falls into an aggressive subtype, it may actually affect, for example, decision of timing of transplantation. It may affect whether bridge therapy is given or not. There are some instances where bridge therapy is given, and subtype could potentially affect that decision if we know we're going to be dealing with a bad subtype. So I think it's not going to be the only thing, but I think it can modulate some of the other decisions that are made. Again, we need to bring biopsy back to HCC.
Yeah.
Thank you, Maha, for the very up-to-date and very clear presentation on a very difficult topic. I was listening to your several subtypes and the overlap between HCC and cholangio. And I'm wondering, at the time when I signed out these cases, how many of these cases did I miss on biopsy or did not give them the right classification? In your current practice or in your consultation practice, how accurate do you feel pathologists are going down the taxonomy of this sub-classification on biopsy specimens? And you talked about the sampling issues. You talked about the fact that many of the markers are even heterogeneous within the tumor. How accurate do you feel that we are today on a biopsy? You already mentioned that the problem with the studies is that we really don't necessarily know accurately on the biopsy.
So I think that we are seeing an increased biopsy in our center for HCC. And I think part of that is because they're hoping, you know, especially when MET first came out, they were hoping that we could stain them for MET. But I think also because they are doing radiofrequency ablation on hepatocellular carcinoma, they feel that that might, at the time of ablation, might be the only opportunity to get a tissue sample from the tumor. So there have been extraneous factors that have led to increased biopsy for HCC. And the problem with accuracy in the biopsy is that biopsies are still not performed frequently enough for us to do accuracy. The heterogeneity is definitely one of the arguments against biopsy. But I think if you do the biopsy and you catch a bad actor, I think that becomes important. Of course, there will be cases where you will do the biopsy and get the nice part. So for example, we sometimes get cases where we're told radiologically, this doesn't look like, this looks like a cholangiocarcinoma, not hepatocellular carcinoma. And we look at it and sometimes it's actually a very straightforward HCC. That's when we're able to tell them, you know, we're sure of the histology, consider you might be dealing with a mixed tumor, for example. So again, I think knowledge of these heterogeneities of these different subtypes allows us to tell the clinicians, consider you might be having this. This is how you might explain the disconnect. So it probably becomes more about reconciling disconnects between biopsy and imaging results. And of course, in a heterogeneous tumor, you know, there are going to be differences. It's just what you can catch, you can put to use for the patient. But I still think we don't really have good numbers for accuracy. Again, all of this information is coming out and we don't have a big denominator of biopsies to apply this to.
Yeah. Thank you. think we probably have time for one quick question. Otherwise, I'm going to have to just thank you very much, Maha, for getting you out of bed to present at 6 o'clock at the West Coast. So, but I could see you started with a big cup of coffee. So that helped. Thank you very much, and hope to see you at LA for OSCAP if that happens next year.
I hope so too. And now, as a benefit of doing this, I get to go to work early, which is great.
Okay, thank you everyone for.
Thank you, everybody.